Okay, good morning. I want to welcome everyone here to the American Enterprise Institute, where we will have a very knowledgeable panel discuss the new developments that are likely to occur over the next year on health care and health policy with the Republican Congress. I'm Joe Antos with the American Enterprise Institute, and let me just kick it off with a few comments, and then I'll introduce the panel. It's interesting. This next year certainly will not be a rerun of the last few years, largely because the Republicans did take the Senate. So now they have a real opportunity and a real responsibility to develop legislative proposals in a vast number of areas, not just health policy, of course, but we're gonna focus on health policy today. The health policy is, I would argue, not just from my own parochial interests, but I would argue just in general that health policy may well be the key area in several respects, certainly from a political standpoint, but also from a fiscal standpoint. A lot of other things go on around, and the big health programs spend a lot of money, and if you don't have the money, it's hard to expand other kinds of programs or pay for other kinds of programs. So I think we're focusing in on the perhaps the most critical general policy area that Congress will confront next year. There are, of course, numerous issues. I'll just tick off a few things that you already know. Of course, the ongoing debate on the Affordable Care Act will color virtually everything that Congress does in health policy over the next year. For Republicans, there's the ongoing debate, is it repeal and replace? Is it just repeal? Is it targeted changes to the ACA? Is that undercutting the foundations of the ACA, or is that making the ACA work better? These are all ongoing debates among the Republicans on the Hill. If you're going to do something, whether it's a full repeal bill or whether it's a smaller bill of any sort, do you use reconciliation? I mean, after all, the Senate is controlled by the Republicans, but they don't have 60 votes, and so anything that they take up can be filibustered by the Democratic Party. So do you use reconciliation? And I think there's a lot of misunderstanding about whether that is an easy thing to do and what's really required to do a reconciliation bill. And then, of course, there are the court cases. The case that's probably on most people's minds, what's the King? It's King, right? King versus Burwell. There are so many of them. King versus Burwell. The Supreme Court decided to take that up. This has to do with whether the Federal Exchange can distribute premium subsidies. That's obviously a big deal. Folks in the chattering class on the Democratic side say that this is the end of the world. Maybe it is, maybe it isn't. But clearly, that's something that if the court goes in favor of the plaintiffs and against the government, something will have to be done. And the question is, what is it, and will it be done? But there are other court cases. There's a new case, House versus Burwell, which addresses the legality of spending money if you don't have appropriations. It's kind of an interesting technical question, but it really matters because the money we're talking about is subsidies for cost sharing. That is to say, to reduce the out-of-pocket costs that people incur when they get insurance through the exchanges. And then, of course, the recent rumblings about the IPAB, the Independent Payment Advisory Board, and whether that's constitutional or not. It's interesting. That could be a court case at some point. Then a few other things. There's obviously some problems with the ACA. Leaving aside the political issues, there's some problems with how the ACA works, and I think that there is, in fact, some bipartisan support for some things that in a possibly a different world, and maybe we're entering a different world, possibly there would be bipartisan support for certain changes. Certainly, the device tax, the medical device tax, is widely regarded as a negative thing. Now, that might have something to do with politics. I really wouldn't know. But the employer mandate also, folks on the left have begun to say, gee, the employer mandate's a real problem, and we don't really need it anyway. So, there may be other issues like that. But where does that fit in with all these other maybe larger considerations? That's a good question. I'm sure the panel will be able to tell us in detail. And then finally, there is running the government. I kind of started off by saying something about the fiscal aspects of all of this, and so I want to end with that. We're going to need cost offsets for almost anything that we do in the coming year. Not just in terms of maybe making changes to the Affordable Care Act, but also some nitty-gritty problems. For example, physician payment in the Medicare program, that remains a problem, and that will cost 25 or 30 billion dollars just to get the cut pushed to the end of next year, and a lot more than that if there's a so-called permanent fix. That's a lot of money. Where are we going to get that? There's obviously some potential targets. One possibility that I think people are beginning to look at from the Republican side are the generous match rates in Medicaid for the Medicaid expansion. It starts off with the federal government paying all of the costs for the new people and then tapering down to 90%. If you took some money out of that, that would be a lot of money. Of course, now this is taking money out of the major health program for low-income people. So how does that play politically? There are lots of issues here, but I know they're all going to be resolved in this panel. So let me introduce my colleagues here. Jim Capretta is associated with I don't exactly know what your title is, Jim, with the American Enterprise Institute. You're a visiting scholar, and he's also a scholar at the Ethics and Public Policy Center. And he's had a long career on kind of the budget side on health. He ran the division of OMB that was responsible for, I don't know the name of the division, but responsible for health and other social services. And before that, he was with the Senate Budget Committee and the House Ways and Means Committee. Then we have Keith Fontenot, who is a visiting scholar at the Engelberg Center at Brookings Institution, and also associated with, I guess it's a law firm. Keith and Jim actually had the same job. Was it back to back?
No, there are
a few people in between.
Yeah.
But Keith also has had a long career. He spent some time at the Congressional Budget Office and good bit of time at OMB. Next, Doug Holtz-Eakin. He heads the American Action Forum, but prior to that, he was the director of the Congressional Budget Office and has been deeply involved with all of these issues for many, many years. And then finally, Chris Jennings. Chris is now in the private sector, but he's had numerous positions, high-level White House positions, not only in the Obama White House related to health policy, but also in the Clinton White House. So this is an experienced panel, and they know exactly what's going to happen next year. Jim?
Okay, well, thanks very much, Joe. Just to add to the story here a little bit more, that Keith and I had the same job at the OMB, not back to back, but a few years in between. But actually, the story goes back a little bit longer than that. that he actually hired me for my first job in Washington quite a long time ago, and brought my lovely wife Claire, who's here in the audience today, up to Washington, and we have been here ever since. So I think in some ways we can blame Keith for bringing us to to Washington. Okay. So, no, it's great to be here this morning, and thanks, Joe, for the introduction. It is nice to be here with Keith and the colleagues, so it should be an interesting discussion. The title of the conference is, What Will a Republican Congress Do on Health Care? Of course, the appropriate response to that is who knows, really. But there's a lot of balls in the air. So my remarks really are not necessarily going to answer that question directly, but will be more in the vein of, here are some things that might happen, as well as some of my hopes for what will happen. Okay, so first of all, it's just really, put the elephant in the room, of course, is repeal, right? So you have to deal with reality, which is that a lot of these candidates who won in the past campaign ran very strongly on repeal of the law, and it resonated with a lot of the electorate, and they won. Now, President Obama's made the point that only 1/3 of the electorate voted this year. Quite true. The electorate will be different in 2016. Absolutely right. But the reality is, you're not going to be able to convince these candidates that they didn't connect with a lot of voters by telling them they're determined to do something very different. And so there's a lot of energy to stay true to that and keep faith with their voters and vote on repeal. So what does that mean exactly? The most likely scenario is that they take it up and they vote again on repeal in the House of Representatives early in the next session. As Joe indicated, of course, the Senate rules are such that a filibuster would apply to normal legislation. And so if you took up the House passed repeal vote in the Senate, who knows what would happen exactly, but most likely is that the Senate Democrats would filibuster the motion to proceed, and you would never actually get on the bill, and it would die at that point. That has led a lot of people to say, well, shouldn't the Republicans then use the reconciliation process that Joe alluded to get a clean repeal bill all the way through the Congress to the president's desk, have him veto it, and then use that as a clarifying issue contrasting issue going into 2016. I just don't see it playing out like that for a number of reasons. One is that it will take about 5 or 6 months probably, at least, for the Republican Congress to figure out a budget resolution plan that would set in motion a reconciliation bill, and then it would take them another few months to process a reconciliation bill. So by the time you got to that, you'd be probably 7 or 8 or 9 months into the calendar year, at which point the politics are different, the presidential campaign's underway, the whole thing feels a lot different if you go down that road, all for trying to get a clean repeal vote on the president's desk, which everybody knows he'd veto anyway. So it seems to me that that's a huge investment in energy and political time and effort for something that's a foregone conclusion that doesn't really get them that much. Moreover, it's not really the best position going into 2016 anyway. Most of the members of Congress are not for just clean repeal, they're for repeal and replace. And so if you vote just on a clean repeal bill, you're leaving yourself exposed to, well, what's your plan, et cetera. Now, that vacuum would likely be filled by the presidential candidates, but I think it still leaves individual members of the House and Senate vulnerable if that's the position they've officially taken in a vote. So I think the most likely scenario in repeal is that it gets out of their system early and that it gets filibustered in the Senate and then they move on. I don't know if that's how it will play out, but I think that's the most likely scenario. The next thing on the agenda, though, is this anticipation of the King case. No one can handicap the Supreme Court. So, again, nobody really knows what the court will do with this particular case. But it does raise the issue that the Republican Congress will have to be ready in the case that they rule for the plaintiff. Because if they do rule for the plaintiff, there'll be a lot of celebration amongst conservatives for a day or two. And then suddenly there'll be this massive problem on their lap, which is that there are, roughly 5 million or so people in the federally run exchanges who are getting subsidized insurance through through that process. And what happens to them? Okay? That will be the urgent question. The administration surely will construct an easy workaround. They will construct a way to designate the federal exchange as a state-built exchange for purposes of whatever the Supreme Court decision looks like, if the court ruled in favor of the plaintiff. That would allow states to easily allow the credits to keep flowing. All they have to do is sign the dotted line on some piece of paper the administration will construct. Of course, most of the states that are in question here have substantial Republican control of state government, so it's not likely that they would jump immediately into that, okay? I think the real question is, what would a Republican Congress do as an alternative? If that is something that might happen, they need to prepare in advance some kind of legislation that says, if the court ruled in favor of the plaintiff, here's where we would go, giving the states an alternative structure that doesn't conform to the current rules, but provides for a transition for the people that were getting the credits and moves toward a new system of some sort. What would that system look like? It'd be, one place to look is the legislation that's been introduced by Senators Burr and Hatch in the Senate, probably the most viable, quote, replacement plan currently on the table. It provides for credits, but in a much more flexible manner than the Affordable Care Act. It provides for Medicaid reform. It provides for a new insurance regime for allowing people to stay protected from pre-existing condition exclusions as well as premium adjustments based on their health status. It's a different structure than the Affordable Care Act. That would take some work, though, and some convincing amongst the Republican caucus. There isn't unanimity about this yet. And so, one thing to keep in mind is, and I'm sure that there are people up there thinking about this, which is that they have to kind of anticipate, even if it's a 20% probability that the court sides with the plaintiff, they better be ready with something, because that will be a big event if they do. Whatever they do, by the way, and getting ready for that eventuality could serve also to be part of the mix of ideas they put into a reconciliation process. I mentioned earlier that I think it would be largely a waste of time to use the reconciliation process to try to just to get a clean repeal bill on the president's desk. It would not be a waste of time to use the reconciliation process to begin rolling back the things you find objectionable in the ACA and replacing it with things you find more preferable for the way the health system should be structured. And so whatever they construct in the case of a fallback in case of the King case could serve also as the elements that might go into a reconciliation bill. Let me just talk a little bit about some of the additional things that probably will be on the table in that kind of a process. There's the issue of the risk corridor payments. There's a lot of people that are viewing the non-budget neutral payments of risk corridor payments. For those of you who are not following this minute by minute, but like all of us, be grateful for that, by the way. The risk corridor payments are those three-year payments that are paid through the bill that essentially allow, the idea is that the losers in the exchanges, the insurance plans that lose a lot of money, get made partially whole by the excessive winners in the exchanges, okay? So you redistribute some of the profits from the winners to the losers, taking some of the risk out of participating in the exchange process. The issue is that the administration has made it signaled to the insurance plans participating that they would do this in a non-budget neutral way if they had to. That, of course, a lot of this is based on risk. And so an insurance plan can say, well, I'll be made whole if my plan loses above X, even if that exceeds the amount of the winners, okay? So it kind of creates a downward pressure on the premiums that otherwise wouldn't exist. If you ask the actuarial professionals out there, they all agree that this has put a downward pressure on the premiums. For those who are saying, hey, if this is a real market, why are we putting taxpayers at risk for this? So that's one issue that I think will raise its head in the coming months. Obviously, the most unpopular provisions in the law are the mandatory requirements, the individual mandate as well as the employer mandate. The employer mandate, in my judgment, is basically a mess at this point. It's a data collection mess, and it's burdensome. The employer community dislikes it very much. It's not all that clear it's very effective, and there's probably going to be bipartisan support for rolling it back to some degree. So look for that to be in the mix. The individual mandate's a different story. It's obviously, from the view of the administration, central to the workings of the law, but it hasn't really been enforced yet, right? I mean, the rubber hasn't met the road on this one yet, but it will in the next couple of months. So, by the time people are filing their taxes in March and April of this year, there's going to be in the neighborhood of 5 or 6 million people out there. They're going to owe the tax for 2014. And maybe more, actually. It could be as high as 7 or 8 million people because, there's still roughly 40 million people uninsured. So a lot of them are exempt, but not everybody. And so what happens when all those people start finding out that they owe 1% of their household income in an additional tax? Is that going to cause a political event to occur this spring? I think it's possible that it will, which could lead to some further revisiting of how the individual mandate works. Back to the issue that was very prominent in the end of 2013 and still is in some parts of the country very prominent is the keep your plan if you like it concept. That still hasn't really gone away. The president made a couple of ad hoc adjustments in the application of the rules to allow some people to keep their plans under some circumstances. It's sort of outside the law. It's done through administrative procedures. I would look to see Congress clarify that in statute at some point during this calendar year. IPAB, Joe already mentioned that, the Independent Payment Advisory Board. It's unlikely to get off the ground anytime soon. There's probably going to be bipartisan support for getting rid of it under some circumstances. The president will defend it, but he may not be able to sustain that position depending on the political circumstances. I think there's also likely to be some effort to revisit some of the key Medicare provisions that were enacted in the Affordable Care Act, some of the changes to Medicare Advantage, some of the the CMMI, the Centers for Medicare and Medicaid Innovation. It's probably not really well known that agency gets mandatory funding, $10 billion, totally unrestricted money, that they get again at the end of 10 years, and then again at the end of that 10-year period. It's pretty, I've never seen anything quite like it for an administrative agency, honestly. And I think once people start examining it, they're likely to want to get rid of that too. So there's a number of other things. Look, it's I think one thing to keep in mind, as Joe indicated, is there's a huge legislative agenda here for a new Republican Congress to work on. It covers all kinds of stuff. Some of it appears small, but it was big at the time it was enacted. It sort of just depends on, it's all a little bit in the eye of the beholder. So, one big piece of advice for the Republican Congress is start legislating, because you got there's a very, very target-rich environment if you want to do things differently, because lots of legislation was enacted without your input. And so if you want to do something differently, now's the time to start working on it, and you never know, some of it might actually become law. I think I'll stop there and we can go on to the next panel.
Thanks, Jim. You're mentioning this sort of permanent $10 billion every decade mandatory payment to the Innovation Center. I ran the equivalent of the Innovation Center a few decades ago. Why didn't we think of that? Keith?
This on. There we go. Are we on there? Okay. So I should tell the rest of the story that Jim didn't tell. No, not only did I hire him, and he was a great employee, and he actually had the job I had at the time. Then he came back and became my boss in the Bush administration. So then the job that I had later on was his job, but only about half of it, because it didn't have Social Security and all the other stuff. I couldn't handle all as much as Jim could handle, so I had to skinny the job down a little bit. But suffice it to say, and Doug and I worked together back in the same era in the Bush administration, and Chris back in the Clinton administration. So good friends. Even Joe, I think, was back in that era. That's right. So my crystal ball is completely cracked. Okay, I have no ability to foresee what's going to happen. But I do want to offer you a couple of thoughts on what I think should happen if it could, and then and talk about some of the things I see sort of as dynamics in the agenda. And I agree with many of Jim's points here. The first point is to commend Joe for doing this, because I think actually our political discourse may not be there, but at least if we can get people outside talking about what can we do, what are sort of the reasonable things we might sort of focus on, that's a good start, at least. The second thing is I picked up this edition of Modern Healthcare yesterday. Since I've gotten out of the budget business now, in the budget business, what you do is you proclaim the bad news all the time. Woe is the budget, and things are really bad, so you can't have any money. And I was actually struck. I'm trying to turn over a bit of a new leaf and see some things in a positive light. And I picked up the edition of Modern Healthcare, and I was stunned by two things. First was the announcement by CMS that healthcare costs were at a 53-year low, which is just startling when you think about it. And the second one, in the same breath, was basically that the uninsured were down. The uninsured rate was down by 10 million people, or about 30%, according to an Urban Institute analysis. And then I read further down, and it talked about Arkansas and a little bit about Utah pursuing sort of innovative kind of new models in the Medicaid space. And I sort of stepped back for a minute, and I said, wow, as we think about healthcare, remember there's a lot of stuff going on out there. And that ought to serve kind of as a backdrop to some of our thinking. Now, I said I'd sort of tried to turn over kind of a new leaf as a former budgeteer, but not completely. And I want to tell you my third point is that there's no reason to rest on your laurels because of any of that. Now is the time, if you go back to the old adage, fix the roof while the sun is shining, now's the time to actually continue the momentum. We have a lot of issues to deal with in the healthcare space. Healthcare still comprises an extraordinary share of the budget and will continue, and a large share of the growth over time. So this is not to say you shouldn't do anything. It just says, remember, the backdrop now is very different than the backdrop before, and we'll color some of these things. One of the things, and actually Doug taught me this many years ago, and it was out of a CBO report I'll never forget, says there's only two things that matter in the long run in the budget. Number one is healthcare, and number two are taxes, right? So if you're thinking about the course of the budget, and if the issue is the debt levels and all these things, those are the two things you really need to think about, because that's what drives long-term growth. We're in a good place now, but there's every reason to believe that things could rebound. It's seen it happen before. But I think we need to step back and say, what's the baseline we're working from, and let's look at that as it colors and influences sort of what goes on in Congress. Second part of that is that there's a real danger that if we don't continue to push things to move away from fee-for-service as a model of payment, that we can exacerbate some of those problems and help bring it about. So I think this is a good time to think about finding some reasonable paths forward, particularly in sort of, doing different things besides paying, in the old fee-for-service sort of model. So that leads to my sort of fourth point, which is, and I think Jim was kind of alluding to this, and I'll say it slightly differently, is that rather than try and fix everything all at once and upend the whole system and redo the whole world, we're much better off if we think about this in an incremental fashion. In other words, we don't need to necessarily, it would be great if we could come up with a plan that would fix debt and debt ceilings and deficits and everything for all time. But I think that's kind of a unrealistic expectation at this point. We tried it a couple of years ago on the fights around the debt ceiling. I would advocate an incremental strategy of finding some things we can actually do and try and legislate those and start a process working. Through the 80s and 90s, and Jim and I worked on many of these bills at the time, we had virtually biennial reconciliation bills, and we had a working mechanism and a process. And those bills did a number of things. Besides ultimately taking down the deficit by large amounts, they were also used incrementally as ways of advancing many objectives in society. The Earned Income Tax Credit, Medicaid, many other things were part of those kinds of bills. So incrementalism is a good thing in my mind. You have to create, Jim and I went to the same graduate school, by the way, so we keep going back to this. And we had a professor who used to talk about the logic when you're cutting back the budget, the logic when you're trying to retrench is different from the logic when the budget is growing. It's not we carve up a pie at the increment, but you need to create a perception that what you're doing, which is painful. I mean, look, you're going to take money away from somebody, do something else. That's not an easy thing to do. You got to create a perception and a reality that what you're doing is for a greater good, right? And that's why I come back to this backdrop of healthcare costs are low and the uninsurance rate is coming down. I mean, that's a good backdrop, but it's also something you could easily make worse if you're not careful. As part of this, I think you'll see a lot of debate around budget process. And having been a student of the budget process for far too many years to count, I'm a fan of an old Rudy Penner quotation. Rudy said years ago, the process is not the problem is the problem, right? And so I would encourage you not to get lost in these kinds of budget process debates, be it a balanced budget amendment. It's not to say there's not process improvements that could be made, but that we have the technology and the reconciliation process, the budget resolution process and all this to actually do some things on an incremental basis, and I think that would be a good thing to do. So let me suggest a couple places where you could start. First is every year we have this annual, Joe alluded to, $25 billion for our annual let's kick the can down the road event in the SGR world, in the doc fix as it's called. To actually fix that permanently and to deal with about what is now a large array of what are called extenders. These are things like temporary medical assistance in Medicaid, qualified individuals in Medicare. There's a whole host of provisions that expire on an annual basis that have been renewed on an annual basis for what, you guess, 2 decades now? Something like that, 15 years, right? And so we could sort of, instead of doing that on an annual basis and chewing up a host of congressional time and energy, try and fix that, okay? But that bill probably in total is in the range of $150 to $180 billion. There's a bipartisan, bicameral agreement on it. 3 committees have all signed in. Now the new chairman might want to take a look at it and put their own imprimatur on it, and they could and should do that. But that's a good place to start. What there haven't been so far is a discussion of how to pay for it. And I can understand that. Those are not pleasant discussions, but at some point people have to sort of get to sort of a reality there and sort of say, well, what are we going to do with this? But that's not the only thing that's out there like that. There are a whole host of things that are coming up where people have indicated there's some desire to do something. CHIP, which expires at the end of 2015. There seems to be some interest in doing something there on a bipartisan basis. There's a host of other ones. The National Health Service Corps, there was additional money there that goes away. Community health centers. They have a large hunk of money in 2015 that disappears in 2016, and those are an integral part of a lot of the health system for the poor. Primary care, there's a lot of areas where things expire and move on, and so people need to talk about all those as part of some larger package, and that's just a piece. Jim alluded to a number of other ones, right? The medical device tax and other things. That starts to add up to a fairly substantial amount of money, and we need to start talking about, if we're going to deal with this, how to pay for it. So as to what will happen, as I said, my sort of crystal ball has a large crack in it. I'd like to see people actually start with these incremental things and try and they're big increments, and try and actually make some progress so we can clean out the underbrush, stop kicking the can down the road every year, and then actually move forward to legislating on problems in society. If you look at what's on the agenda, whether or not they do the omnibus or the cromnibus, as people are calling it, the combination of a continuing resolution and an omnibus spending bill, has some major implications. Because if not, if there's a short-term continuing resolution, then the first thing a new Congress walking in has to do is move $1 trillion spending bill. That's a tall order in any event. It's not a pleasant thing to do. And it chews up congressional time. And if Jim alluded to this, and I think he's absolutely right, one of the most scarce things in any corporation is an executive's time. And the legislative calendar is one that just gets so clogged, and it's so little time to do all that needs to be done. The second one, I think it's almost imperative that this new Congress will want to have a budget resolution. Having made an issue around the budget, then they're going to have to follow through. So having a budget resolution provides also the machinery to use the reconciliation process. Whether or not people actually fix the SGR and take care of these other problems that I alluded to you're still going to have to deal with the doc as doc fix simply as an extender. I'd like to see it done permanently, but there's still even if you don't do that, you have to extend it because it expires in March. And there's this other little thing that hangs out there that's had a major influence on healthcare called the debt ceiling, right? That was a very painful. I was working in OMB at the time for Jack Lew and spent I don't know how many months on the debt ceiling the last time around. And what happens there could either provide impetus or create a major problem depending on how it's handled. But that's not an easy vote for any member of Congress ever. And so that's a lot of stuff just right there in 1 year, to be frank. And then you have, as Jim alluded to, these curveballs that could come in the form of changes in King v. Burwell. I'm no soothsayer on the Supreme Court either, who knows. But he alluded to something very important, which is it really does change the baseline. And I say baseline in both a kind of a political sense and in a budgetary sense. If the Supreme Court rules against the administration's position in this case, and the reason it does that is if all of a sudden, and if the Supreme Court were to draw a clean line on what a state exchange is or is not, then those states that are not considered state exchanges either decide to become one, and perhaps there's administrative remedies, as he alluded to. But all of a sudden in those cases, those are subsidies that are now being paid that are no longer being paid. And under the baseline rules by which you judge the budget, the Supreme Court decision becomes current law. So anything you do to replace those subsidies in those cases now cost you money, even though you legislated them a few years ago. So the baseline shifts here, both in a budgetary sense and a political sense, are really significant. And so to replace it with whatever it is you want to replace it with would then, at that point, cost you some money. So then you add to the list of things I talked about earlier, positions, expiring provisions, all these kinds of things. The list of things that Jim indicated that people might want to deal with: the device tax, the employer mandate, the health insurance tax. Senator McConnell, I heard, alluded to that the other day. The individual mandate. That's a substantial amount of cost on a lot of items. The individual mandate's a little bit of a different item, but let's set that aside for a moment. So finding offsets to pay for all this is not easy against the backdrop where healthcare costs are growing very, very slowly, and where a lot of the Medicare cuts have already been taken. I think I'll stop there, but I should also say that the situation this time around in terms of electoral politics is reversed the next time around, when all of a sudden there's 24 Republicans and 10 Democrats up for election. So Senator McConnell is an extraordinary leader, tactically, strategically, a brilliant man, and he's going to have a heck of a challenge to try and manage that process. So I'll leave that there. Doug?
Well, I want to thank Joe and AEI for the chance to participate in this, and obviously there's an enormous amount that's potentially on the agenda, and I think the most important thing is to sort of step back and look at the surrounding framework in which they're going to be operating. And the first thing I'd emphasize is not all Republicans are the same. And the notion that somehow the House and the Senate are going to move in lockstep and agree every single day on what the agenda is just, I think, completely misplaced. Senator McConnell said his top priority is to restore the Senate to regular order and move legislation. I'm pretty sure that's not the House guy's top priority. And so just how this will play out, I think, is going to be more interesting than has been perceived. There isn't this monolithic Republican approach to things. Second thing that I think is important in terms of framing this is, of the 60 Senate Democrats who voted for the Affordable Care Act, only 31 are left. And so there are a lot of Democrats in the Senate who have no personal history of voting for the ACA, have no particular reason to line up with the president in again, monolithically blocking any changes to the ACA. And as a result, I think there will be a chance for McConnell to find the 6, 7, 12 Democrats on smaller pieces of change that will allow them to send bills to the president for signature. And I think that's going to be an important dynamic. And then the third important thing that's going on is the budget context, where the current caps on both defense and non-defense spending are simply giving everyone a lot of pain. Republicans certainly want the defense spending to go up. There are a lot of Democrats who are comparably unhappy with the level of non-defense appropriations. And the way to get more money there is to go find mandatory savings. And that means you go look at the health programs. And that's going to be a bipartisan sort of objective. And so in that setting, I think there's the real chance that you'll see some activity, and you'll see that activity focusing in the health area because it has to. So in terms of the big things, I'm going to agree. I think Jim's got the analysis of the repeal just about right. The only issue is whether the Senate really wants to have the first thing they do be vote on repeal, this old tired thing. They're going to need to do it at some point, but McConnell may want to pass some things first, prove that they can get stuff done, and then come back for a repeal vote. There's an argument to be made either way. I'm sure it hasn't been settled, but at some point they're going to have a bill come out of the House, and they'll vote on the motion to proceed, and that will be the vote on repeal. Everyone will be on record, and we'll move on. The question is just a timing one. They will then have to do a budget resolution, and they'll get reconciliation instructions, and they will use that for some of these smaller changes if necessary. You can probably even do some of the insurance regulation reform they want in reconciliation because it'll have budgetary impacts, and so that's something they'll want, and they're trying to figure out the best way to use it, but they won't use it for a repeal vote. I also don't think anyone should have any expectation of seeing a replace plan. I mean, the reality is the Democrats never agreed on the health care reform until they had to. I mean, until the ACA was on the floor and they had to vote. Republicans are not going to agree on the health care reform until they have to. And that's probably going to be at earliest when the nominee in 2016 says, this is what I want. And it might even be later than that. But I have no illusions we're going to see in 2015 the Republican replace plan somehow emerge on a consensus basis. It's just not in the cards. So instead, the list of things that I'd focus on are first, what do you have to do? Well, you got to do something on physician payment and Medicare. You got to do something with the SGR. And that'll be a focus early, that the clock's ticking on that. They will have to do something on the CHIP program. It runs out of money at the end of 2015. The CHIP program as it exists right now doesn't fit into the healthcare landscape at all. The ACA sort of changed the sort of target group that really doesn't have access to insurance, and so it does need to be reformed, and there's a good history of bipartisanship on CHIP that they might want to restore. Some bruised feelings from the 2008-9 period, but they can get back, I think. And there's also the disability insurance, not directly a health program, but Social Security disability runs out of money in 2016. They need to do something on that. So some things they have to do that are not enormous, have to be bipartisan, and are a good place to start. Then there's a list of things they want to do, which is the device tax and IPAB, and probably the employer mandate, or at least the 30-hour rule for part-time. Something will come out of that. Maybe they'll go to the individual mandate. I don't think so. And Republicans at least are concerned about the future of Medicare Advantage, the home health programs. The sort of pay-fors in the ACA have never sat well. So there'll be some desire to sort of take on those things if they have time, and if they can figure out where they're going to get the money, right? So those are on the want to list, but no, I don't think there's a clear plan. And then you have the two wild cards, one of which is the Supreme Court, and I think I don't think that's anything other than a political earthquake and a legislative imperative. The money's not going to stop flowing, no matter what the Supreme Court rules. The administration has said they're going to keep making the payments. I mean, they told the district court, they said, it doesn't matter what you say, we're making the payments. And if they make the payments and they waive, as they have in the past, the employer and the individual mandate, no one is standing to sue. So nothing's going to happen in 2015. But there will be an imperative to legislate and be ready for 2016, 17, 18, see what they do. And I think Jim's diagnosis was exactly right. Republicans most likely will simply go to something like the Coburn-Burr-Hatch framework and say, this is our preferred subsidy program, put it in place, and go from there. And so they have a place to go if they need to. The other wild card is the tax filing season, which is going to be a disaster. I mean, there is no way this is going to go well. it's simply impossible to believe when you get down to it that anything like accurate subsidy payments have been made. The Earned Income Tax Credit has about a 25% payment error rate, and it's 1,000% simpler than what the ACA has. So the subsidies are going to be all wrong. Lots of people are supposedly going to have to repay. Some people are going to have their not be in compliance with the mandate, and that's going to be a mess. And what comes out of that, I don't know. But there's going to be just a renewed appetite to fix things in the ACA, and I think it's going to make the issue of getting these Senate Democrats who have no history with the ACA on board with some of these bills and get them through. So I think that's what we're likely to see: stuff they have to do, some things they want to do as long as they have time and money, and then reaction to the earthquakes, because they're coming.
Doug's always helping me. I'm here to talk about the Republican agenda, and frequently people come to ask me to discuss and to develop strategy and to make recommendations. So this is something new but fun. I would just say that we're up here, and actually all of us have been doing this for probably way too long, and not just today, but for our lifetimes. And we would like to engage in a exchange of questions and answers. So I won't be too long. Mostly because I can't say that I disagree with much of the assessment that's been made, because really it's not my place to disagree with and I'm setting Keith sort of aside, but what other people are projecting. I do think that Doug made a very important point, and this happens with Democrats as well as Republicans. When you get a majority, you find your divisions become even more visible. And I think that while people may say this is what Republicans should do, there will be such divisions. I mean, right now Republicans are still debating about whether they want to dismantle, replace, fix, improve, undermine, whatever. So, I've been in meetings with opponents of health reform who get mad about policy changes to the ACA because that might fix it, and that or could sustain a law. And until there is sort of a resolution of whether you want to allow something to continue, or the very act of doing that is somehow inconsistent with an agenda, I think it's just going to be quite difficult to reach a consensus. And I think you'll see that particularly in the House versus the Senate, but even in some elements of the Senate. So there's going to be that dynamic, and again, as I say, when Democrats were the majority, you saw these divisions as well. The agenda that I guess I'm hoping Republicans engage in, if you want to be bipartisan about this, I think you look at where there has been some bipartisanship already, which is the SGR legislation. It currently exists. It's bipartisan. It's bicameral. It really begins to address some of the broader consensus that all healthcare delivery folks are now coming to, which is they want to move more away from fee-for-service and more towards value purchasing. There's a lot of good thinking in that law. I wouldn't say it's perfect, but it's good. And frankly, if the Congress really wanted to show that they're doing something, that would be very important. Now, as for the offset, I would just make a little bit of a case for an acceptance that, and we can talk about all the reasons why the baseline's come down so far, but the baseline since the enactment of ACA and Medicare, Medicaid have come down hundreds and hundreds of billions of dollars, far below what CBO projected. So it's kind of ironic when people are saying the past CBO was overly favorable to the administration's ACA proposals, when the subsequent analysis shows that they actually overestimated cost, not underestimated the cost growth. So the baseline is, I would say, if you look at it, 600-700 or up to $1 trillion below what CBO had projected in 10-year periods of time. And I would think that recognizing that, and look, Republicans aren't paying for tax extenders, you know. It seems to me, looking at the SGR, about looking at those and acknowledging some of those reductions in baseline could be utilized for an adjustment to offset the cost of the SGR and mitigate against the need for having dollar-for-dollar offsets for SGR. Now, if you're going to require it, I just don't see Republicans or Democrats agreeing to $130, $40 billion in new Medicare cuts. And this goes to my next point, which is when you look at the history of when Congress can make significant cuts in the program, it's when growth rates are pretty high. When growth rates are really, really low, getting scorable savings from CBO off of almost any policy is going to be extraordinarily difficult, and to the extent you do, they will be painful policies. They will be politically painful policies. So I would just suggest to you, not that we shouldn't do everything possible to sustain the recent success in cost containment. We should, and that's why I'm advocating to do SGR reform. But if we are going to insist for dollar for offsets, I think we may actually be making a very, very penny wise, pound foolish decision in undermining our ability to sustain cost containment success story that we've seen. I also do see and agree that the CHIP legislation, which ironically, because of the enactment of ACA, the reauthorization cost of ACA is going to be very, very small. I think that policy is something where Republicans and Democrats have in their interest, for different reasons, to come together and collaborate on this. I'll tell you why I think it's in the Republicans' interest. The one problem that they have many challenges governing. By the way, welcome to governing. That's going to be a lot of fun, guys. Which is that you've been very critical about not passing a budget resolution. Now you're going to be having to pass a budget resolution. You're going to have to reflect what your priorities are. You have a lot of priorities. You have significant deficit and debt reduction. You want to increase spending on defense. You want to cut taxes, et cetera. And if you aggregate all the priorities of the Republican messaging, it's not a cheap, or it's going to be, they certainly are very difficult to reconcile the desire to substantially reduce the deficit and achieve those objectives. And if you also consider the fact that the discretionary budget has already been squeezed very, very significantly, and it's going to be very, very difficult to get a lot more savings, you kind of come back to one really, I think, indisputable fact, which is they're going to have to come up with a budget resolution that scores some significant health care savings. And whether that's big cuts on ACA or big cuts in Medicaid, they're going to have to propose that if they want to be consistent with their messaging around deficit and debt. And that will be my last point about what I think will happen in terms of just their budgeting, which is I think we will go through an exercise where we'll be seeing significant cuts, and I would project, particularly in the Medicaid program and ACA, not so much in Medicare unless they can get some Democratic cover so to do, because in the Republican Party, the base of the Republican Party is old white people like us up here, and it's just not a very popular thing to do to cut Medicare unless you do have some bipartisanship. And that will require collaboration. And that's why I would start with the SGR and CHIP in order to be able to develop those type of relationships. The last point, and I want to just say this because I served 10 years in Capitol Hill in the Senate, and I really do lament the dysfunction of the Congress. I think that we have substantially weakened our government by not having a strong Congress. Our Congress isn't doing oversight well. They're doing gotcha oversight, but they're not doing thoughtful oversight. They're not doing thoughtful reauthorization process. They're not doing thoughtful committee process. They're not doing thoughtful, almost anything process. They have a hard time passing ice cream social week in the Congress these days, and that's an indictment on Democrats and Republicans. This then inadvertently and ironically cedes power back to the executive branch and to the Supreme Court, which is why you've seen so much frustration by Congress, because they've made themselves largely irrelevant. And then they get mad that they think the executive branch overreaches, and then they ask the Supreme Court to play referee. That's basically the dynamic that exists today. And I believe that if we don't if we don't reorder that, if we don't see a more competent administration of the Congress, we will undermine our ability to govern ourselves. So I'm hoping that Republicans and Democrats can work together, and I will start or end this December 2014 period with a resolution that we will try to work with Republicans to that end. So that's how I'll stop.
Well, thank you. I mean, the level of optimism in the room is breathtaking. Let me give the panel a chance to just comment on each other's remarks, and then we'll go to the audience. Does anybody have anything that they'd really like to get off their chest? No, they're good.
I'll just make one more point about sort of the political dynamics that are going on. And I don't really disagree with much of what was said, but the part of the election story that people haven't focused enough on is the pickup in the House, which actually gives them a governing majority for the first time. Boehner's had an arithmetic majority, but he hasn't had a governing majority, because you lose, there's the Just Say No caucus, and then you lose 5, 6, 8 people for parochial reasons in every bill. He's never been able to get to 218 for sure. It'll be a little bit different now, and so I think that's something people ought to pay a little bit of attention to. And then just emphasize, I think it was Keith or Jim said, it flips in 2016. All those Senate Republicans who need to get reelected need to have something to run on, and so the imperative to get stuff done is going to be pretty high coming out of the Senate.
Okay, thanks. Who has the microphone? Please come up. We're going to start over here, and we're going to work our way over there. So, starting on the you're actually, Randy, it's your right. Further to your right.
You cued me. So, Paul Heldman from Potomac Research. Both Jim and Doug referred to problems with Medicare Advantage and maybe Congress wanting to address some of them. So I was wondering if you could go into a little bit more detail. And then also, I wanted to ask, I think President Obama has almost $400 billion in Medicare savings in his budget. Maybe, there's probably about $150 billion related to the manufacturer rebates on drugs that Republicans would oppose. But what do you think about Republicans taking some of those savings to pay for some of the things that you said need to be paid for?
Well, I'll take an initial step. First, on the second part, you probably recall that back when Vice President Biden was negotiating with then Majority Leader Cantor in 2011, they had a list of wasn't $400 billion, but they had a list of sort of small ball entitlement reductions and reforms that added up to $500 billion or thereabouts. And so they could go back to that list, some of which were Medicare changes, and see if there's anything that hasn't been taken. I don't think most of that hasn't been taken. It's been sitting there. And so they could go back to that list again and see if they could resurrect a coalition to support those. The scoring of them could be altered based on the baseline coming down. But I think there's some possibility for that. To your first question on Medicare Advantage, it's one of these things where the threat of additional cuts is always, first of all, there's a lot of administrative discretion that's played out over the last couple of years. So each year, it's a negotiating tactic. The administration will announce that the Medicare Advantage rates are going to go down by 2% or something like that. And then, after a lot of howling, they say, okay, no, they're actually going to go up by 2%, something like that. It depends on one's perspective a little bit, but at some point, if you do that over a number of years, it's quite likely that the enrollment in Medicare Advantage will start to fall. Hasn't happened yet, but the bigger cuts that are required under the law occur in really 2016 and 17 and 18. So I think they may want to look at that because the actuaries are still saying there will be a precipitous decline in Medicare Advantage enrollment as a result. I do want to, Joe gave us the opportunity to talk about some of the things that were said. I do want to talk a little bit about the cost issue. Keith alluded to the fact that CMS announced that the growth rate in health spending in 2013 was the lowest in 5 decades. This is such a confused situation that it takes a long time to untangle it, which we don't have time for today. We'll have another conference, won't we, Joe, about just this one issue. But to associate the trend lines in the health spending with the Affordable Care Act is really, really dubious. It's just not the case. It's not true. And everybody who's looked at this independently and analytically comes to the same conclusion. It doesn't matter how many times the Council on Economic Advisors says, the sun came up, and boy, isn't it sunny, and the Affordable Care Act was passed just before the sun came up, and you draw your own conclusion, So there's a whole complicated story about what's going on in health spending nationwide. I think the one thing I'd like to point out to people is there's a worldwide trend in downward health spending in every developed economy around the world, including Japan and Australia, Europe. I know people like to claim the ACA is doing great things, but to claim it slowed down spending in health in Europe and other developed countries, I think even they might think that's a bit of a stretch. So, there's a lot of complicated things under there, but let me just leave it at that.
Okay, well, I guess I have to jump in then. I mean, I wish you applied the same standard to the claims of great Part D savings too. Then, I mean, no.
That's another issue,
no.
actually.
I mean, because if you look at what the economy was doing, all private sector purchasers were purchasing generic drugs at a much more rapid pace, which is why the Part D program's costs went way down relative to projections. So, we can talk back and forth about the causes. I don't think anyone would say. And I don't even think even the administration is saying that this is solely related to the ACA. In fact, I don't know if anyone,
Sure they do.
Peter,
Sure
or
they
is that? No, they don't. I think you guys. I think we should actually celebrate the fact that healthcare costs are low and have been since 2008 and have significantly reduced the deficit as a consequence. I mean, that's just the reality. Now, we can talk about all the reasons why, and I'll just say for the record, it's the economy, it's all related to cost sharing and higher deductibles, it's related to Medicare savings, it's related to a whole lot of things. All those things are true, but, and no one economist will say, any credible one, that I know which one factor is the reason why. I don't think there's anyone in the administration who says it's because of the ACA. But it doesn't really matter. It happened. It's good. And really the challenge isn't so much to say the reasons why. The question is, how do you sustain the success over a period of the last point is why, which is why I'm embracing, and I think all Republicans and Democrats should embrace the notion of moving towards SGR reform and thoughtful reforms of how we deliver and pay for health care.
Well, I won't belabor this too much, but
I've never seen you not belabor.
Yeah. Just the couple things. One is that the president himself has basically claimed credit for this, but
he hasn't. But go ahead.
Okay. Well, anyway, we'll get the transcript out and send it over. But the larger point, though, here is that I think people are trying to create the perception, if not the reality, that if you adjust the ACA, somehow healthcare spending will go back up, right? If you, and also the notion that some of the Medicare changes, the so-called delivery system reforms, are related to the health spending slowdown, which is patently not true. They're very, very small, very minor in the scheme of the delivery system, and have nothing to do with the overall spending trend. And so I think some of there is a policy implication to the kind of construct of the ACA passed, health spending is slowed down, you better not undo it because health spending will go back up, which I don't think is true.
Right. Well, this is the last point since you continue to go on, but is just
Fortunately, nobody's belaboring me.
is just this, that actually, if you look at the history of significant debates around healthcare delivery reform, you will find that right around them, almost always there's a compression of cost growth. And it's very interesting, but if you talk today to health delivery systems around the country, so private sector people that you like, I think, is that they will say that actually the debate around healthcare reform, which was really driven by a bipartisan discussion around the Finance Committee white paper, I would argue, on delivery reform, really focused a lot of systems, plans and systems in hospitals to say, in what direction is reimbursement going forward, and how do we adapt, and how do we position ourselves so we can be in a good place if and when that should occur. And I would argue that that is definitely happening, and I don't think you could talk to a hospital system in the country who would disagree with that.
On this one, I do have to pick up Chris's mantle there. I think that the shock to the system of major pieces of legislation like that, the debate and then the actual enactment, if you're sitting in an institution and all of a sudden you see that your market baskets have been reduced permanently by incorporating productivity in those market baskets, you see this push towards, all kinds of different mechanisms of payment. It causes people to do things differently. I don't know that it's driven down the cost in Spain or France, but I do think there is a large impact here. But setting that debate aside, which we'll have in another conference, Chris made this point, and I think he's absolutely right, which is where, with cost growth that low, and look, in Medicare it actually went down on a per beneficiary basis, which is stunning. With cost growth that low, trying to get money out of that system becomes a good deal more challenging. And so where do you go? Would the new Congress seek to go towards beneficiary savings or things like that? I think that becomes a good deal more challenging when you look at the next electoral cycle and all those kinds of things.
Good. Yeah, actually, when people said a couple years ago that the baseline had gone down, so SGR was on sale, of course, that was baloney, because when the baseline went down, you had to have higher percentage cuts to achieve the same savings. So, there's never good news in budget land. Okay, Randy? Wait for the, right here. Raise your hand, Randy. Thank you.
Randy Boberg, I understand we're supposed to identify ourselves normally. I'm at the Urban Institute, and let the record show, Joe, I am sitting in the center. We're seeing, even in a very well-intentioned and exceptional panel like this, we're seeing an emergence of the gotcha and the lack of bipartisanship. Let me make that more difficult by raising an elephant in the room that you didn't address, which seems to me is a problem for left, right, and center, and that is provider power. You mentioned fee-for-service, the difficulty changing away from that and killing the AMA's revenue stream. The difficulty of concentrated hospital markets, which are stunning, along with must-have hospitals. This is a problem, whether you're talking about centralized administrative pricing, whether you're talking about rate setting, whether you're talking about bidding, which I tried and many people have tried to have happen, and there's a bipartisan support for not rocking the boat of established provider interests, which are now more powerful than ever on the hospital side. What are we going to do about this? You talk, okay, we have more cost sharing, all of us, and it's very heavy in the ACA, but all of us have more cost sharing. Have you tried going to a hospital lately? Have you seen your ability to deal with that? We've seen all the hidden prices that come out after the fact that you can do nothing about. What are we going to do about concentrated power on the provider side? This is a very important issue from any perspective.
You can start.
That's depressing. I think it's a good point. I do. Certainly the sort of one of the things that I've been concerned about in the aftermath of the ACA has been consolidation, particularly hospitals buying up doctor groups and a lot of concentration in delivery services. And this was something that the FTC flagged years ago, deeply worried about, and I think it's a fair concern. So one of my sort of pet theories on this front is that the next stage in healthcare reform is really done at the states, where scope of practice and certificates of need and a lot of the things that are going to determine the competitive landscape are really determined. And so, I think we have to acknowledge that and encourage the states to get serious about this. And obviously, the Congress can't do much about that other than to exhort them to sort of keep a close eye on just what's going on, the quality of competition in those local areas.
Just one quick thing. I think that, like politics, all healthcare is local. So it is a very, as you know, very regionally interesting dynamic. And I think clearly consolidation is taking place in particular areas that is troubling, substantially troubling. And it's very difficult to legislate on that front. Far more focused attention is getting done at FTC and Justice, and there will be more of that as time goes on. But I will say that statutory changes in that area are always very rare, mostly because there's a law of unintended consequences, and all the antitrust lawyers then will say that you've done something that you didn't mean to do and you've made it worse than you intended, et cetera, and this is more of an enforcement issue than anything else. But the last point I will say is that until we see these bump ups in significant healthcare cost increases over time, it will be very difficult to have the political environment to see that enforcement take place. And when it does, and I think inevitably in certain areas it will and has, you will see more. Last thing I just want to point out is there is in this policy area intended and unintended incentives to consolidate, to make your system more efficient, allegedly. And some of that consolidation is good. The question really is, as you become more efficient, are you passing along those savings? And can you secure them as purchasers? And I think that's going to be the challenge going forward.
Just as an addendum, last time I checked, and I'll probably have the numbers a little bit wrong, but when the last full year data when I looked, when spending growth was going at about 2%, hospital spending was going at 4.1, like twice everything else. And so I think this is going to emerge relatively quickly as a real issue.
So there are a whole bunch of policies that could be adopted. For example, Medicare pays a lot more money for the same service delivered in the environs of a hospital. I wouldn't want to say in a hospital. This is one of the things that's driving hospitals buying up physician practices and employing more physicians. This is obviously an incorrect policy. It's in essence indemnifying some institutions for some costs that are difficult to justify. So you have those sorts of problems that, in fact, Congress could deal with this issue if they felt like it. This is a problem. The one other aspect, nobody mentioned anything about consumers, but what the heck? Why don't I?
Oh, good, Joe.
Consumers might be interested in this. So there's this growing, I think, misunderstood movement about price transparency. And, price transparency really works well when you have a competitive market. But when you don't have a competitive market, when you only have, say, 2 or 3 sellers in the market, then price transparency is actually a way of signaling to your so-called competitors what the price is going to be. So this is not just a theoretical question. This has been dealt with at least 100 years ago, and not very successfully. And we don't have the answer right now. So I would argue that if we're talking about price transparency and what consumers involved, they have to know the price they're going to pay. And that then involves, well, what is my copayment? Have I satisfied my deductible? It's a very complicated question. More good news. Okay, who's next? John. I'll get you.
Thank you. John Graham from the National Center for Policy Analysis. And I'd like to throw a completely new thing, so I hope I'm not surprising anybody. But it seems to me there's a very serious bipartisan effort in energy and commerce called the 21st Century Cures Initiative. And I'm just wondering if the panel thinks that, it seems to be on a long simmer and not very exciting, but very deliberate and thoughtful. Will we see anything come out of that that will get legislated in the foreseeable future?
Maybe. I mean, right now they're at the sort of puppies, kittens, and sunshine stage. Everyone's happy, and no hard decisions have had to be made. But it's and I think an entirely worthwhile endeavor, and I would like to see something come of it. My biggest concern will be, to go back to the Keith Fontenot rule, they're going to run out of time, and they'll get to 2016 and start running, and I'm worried that that's going to be the problem.
I just think one has to say 2 things about this. It relates to the sectors. I think what people are going to be doing is looking at different creative ways to, again, sustain success and cost. One is investment in R&D and appropriate levels of development, and because at some point in time, if you have lots of people with Alzheimer's disease, you're going to say, I need to have a better intervention than this. On the other hand, of course, if you look at the specific sectors and you look at price increases over time, people are going to be starting looking at the drug pricing and the specialty products. They're going to be looking at incentives in the 21st century policy, and purchasers are going to say, well, are these incentives going to end up being better or worse for us over a period of time, both in the private sector, private plans, and the public sector? And so, as Doug suggests, the details are going to matter here, and the time may be limiting.
Hi, Melanie Zanona with CQ. I'm wondering if any of you think that Congress could deal with the Medicaid doctor pay parity issue before it expires at the end of the year.
I would hope so, but I wouldn't hold your breath.
Yeah, that was what I had when I went through that list of things and alluded. That was one of the things I was alluding to, was the primary care bumps, which expire as well.
Hi, I'm Vic Miller. I'm retired, but I've been in OMB, Senate Budget, Treasury, and GAO, so I call my ex-checkered past. I have 2 questions. Yeah, sure. I have 2 questions here, one of which is, we have a recession every 6 or 7 years in this country, and next year is year 6. So if we have a recession, how did that re-crack your crystal ball? The other question I have is, when I started as a young economist working for Tom Cooney in '72, we had all the power in OMB, and then they gave it to '74, they gave it to CBO and GAO, a bunch of it, okay, and, whatever. But, Joe, I'm going to correct you. The question is not whether you can spend money without an appropriation. That's unconstitutional. The question is whether the ACA gives an appropriation, and same thing with the federal exchanges. So now we've taken scorekeeping and spread it to CBO, and now the Supreme Court is going to become the scorekeeper. Isn't that scary? So those are my 2 questions.
Well, on the first one, I mean, we never fix the budget in a recession, and the budget is health spending programs. So if we go into recession, none of these things get done. I mean, I think that's a reality. The Supreme Court as a scorekeeper, I don't really think of it that way. I think of it as, first of all, on the King and Burwell thing, this is just a question of administrative law. Is the statute clear? If the statute is clear, there's no need for the IRS to write a rule and guess the intent of Congress. If it's clear, you just execute it, and there's no rulemaking. So if they decide it's clear, the whole issue of congressional intent is irrelevant. That's the threshold. So I don't think that's going to end up being a scorekeeping issue at all. On the appropriations thing, on both the risk corridors and in other places in the law, it's not obvious to me that they set up the appropriate revolving funds to do this, and that's what we're going to find out.
Although if I can jump in there,
Please.
I'll start, and then you can.
It's not a matter of they're definitely wrong. It's just not obvious. I mean, this is why they're there.
So on the second one, taking the second one first, there was actually the GAO is the official interpreter of these things. They actually looked at the risk corridors case and said, hey, you know what the administration proposed actually works. They put it inside an appropriation, in this case the CMS program management appropriation, and there's language in there that makes it work. If Congress wants to change that, they could change that. But I don't think there's any issue that one's clean. Around the King case, it does get to what Doug is talking about as a matter of administrative law. Chevron deference, I believe, is the term. And none of us are lawyers, so I think we all should declare that up front. But when you look at that question, you don't just look at the black letter. If you look around that statute at all the cross references, for example, all these exchanges are required to report the subsidies they got. Well, how could you be required to report it if you didn't mean the subsidy was going to be there? So there are two principles of statutory interpretation. As a non-lawyer, I learned one, which is you look at the black letter, and then second, you read it in context. And so having looked at it, I see it as an issue of the interpretation around that. Is it in the context or is it black letter?
It's okay. You have a lot of questions.
Hi, Carl Polzer, independent consultant. It seems like Medicare has gotten its nose under the tent on capital gains taxes because they're now putting in that 3.8% wealth tax. Under the ACA, there was a new tax on wealth. I guess the Paris School of Economics would be proud of us for doing that. Has anybody figured out how much that's getting Medicare? How much, if you bumped it up a little bit, could it get for all these needs that we have for budget in terms of dollars? Why isn't there an outcry about that, like the medical device tax, or is it happening behind the scenes? It seems like a watershed change to me.
So I'm not a big fan of that. First of all, it has nothing to do with Medicare. It was labeled Medicare. It's a surtax on high-income people with the payroll and investment incomes, and it's a revenue source, and that's that. And I think behind the scenes there's now an acknowledgement that it's basically a problem because its definition of net investment income differs from everything else in the individual income tax. And so we set up as a matter of administration and compliance, a parallel tax system with this surtax, and it's a really inefficient way to do it. So I think if there's going to be anything, they're going to have to, as with many of the taxes in the ACA, the health insurance tax and this surtax, the design issues are serious. The revenue was there for a reason, and they may need to replace the revenue with more efficient taxes. These aren't good ones.
Just to follow on that very quickly, if I remember right, of course, there's two taxes. They raised the payroll tax itself for people with that income, and that money, I believe, is getting deposited into the HI trust fund. I believe this tax, they called it an additional Medicare tax, so they wanted to create a parallel tax on non-wage income, but I believe that revenue didn't go into the HI trust fund. It just funded the rest of the bill. I guess part of it is there's so many things that people look at the bill that they find unpleasant, okay, that maybe it doesn't make the top of the list all the time, right? But, when you hear people talk about tax reform and everything, I'm sure those kinds of issues will be swept into the discussion of rationalizing some of the tax structure. But, that's a huge undertaking with lots of moving parts. And so that's just one element in that kind of a conversation.
I do, if I can add just a touch to that. When I said earlier on that Doug had taught me something a long time ago from CBO, which is the budget's two things. It's taxes and it's health care. And that's kind of an exaggeration, but it's true that those are the two big long-run drivers. in the end, we are going to have taxes as part of this conversation, I believe. As part of, if you go back and look at all the bills through the 80s and the 90s, that has to be part of the equation. Doing it right, doing it well, Doug's a better tax economist than I am. I don't know that this one's.
What year were we going to do this?
No time like the present.
No, right here, up front.
Oh, sorry. Hi, Sarah Cliff with Vox. I was wondering if you could talk a little bit about if there is a positive decision for the plaintiffs in the Supreme Court ruling this summer. What do you think happens? It seems like the options range from full-on repeal to fixing the law to just kind of letting it be a mess. What do you see like the outcome in a situation where there's a ruling against Obamacare this summer?
Well, I'll just sort of repeat a little bit what I said earlier, which is that I think first of all, the administration is very likely to build a workaround. So they'll have some kind of ready-made workaround that allows states to designate the federal exchange as a state-built exchange. And so some of the states actually might take that. And whatever they have to do to execute that kind of a decision-making process. Of course, a lot of the states in question have some element of Republican control, and so they're likely to think twice before they jump. Okay, there'll be a huge amount of pressure and a lot of stirring. My guess is that in anticipation of a possibility of a decision like that, there will be some stirrings in Congress in the months leading up to it, saying, if they do rule this way, here's the direction we will go. And, if they're smart, part of it would be to hold the people harmless during a transition and then move towards some alternative structure for those states that don't want to simply designate the federal exchange as their state-built exchange. So I don't know exactly what will happen, but, I think if they're thinking, they're going to probably think about it in those kinds of terms.
Let me just say, I guess first of all, I think under Chevron, the law should be upheld, and I think there are very strong arguments for that. I think this is a much greater threat than many people think. If the court rules the wrong way, I think there'll be many states who will be put in the position of considering not extending, even if one assumes the administration gives them some sort of option. There'll be many states who will be politically very challenged to do that. And if you look at the election, and this is about the election discussion today, the Republican state houses and the Republican governors are substantially increased since 2013, 2014. And so I'd say this is a major, major threat, and it could create huge problems, and people would lose coverage, and premiums would increase substantially. There's just no question about that. So one thing that people haven't thought about, and this is a conversation amongst the best people to talk about this, is that the Congressional Budget Office will be put in a position to make an almost immediate decision as to how many states will not take up any option, even if an option is available. I don't think anyone can presume anything at this point in time, and have to project a change in the baseline, which would then require additional revenue and or cost to pay for, which will make it very, very difficult for Congress to pass legislation, even if there is a bill by the Republicans in the House and Senate to pass. They won't want to have to pay for that. So this is a real significant threat and challenge, and anyone who thinks otherwise, I think, are misreading the current situation.
It's not entirely clear to me that CBO will rush on June 25th or something to change the baseline.
What did they do?
They normally do another baseline in August.
Yeah.
Right, and so by that time, maybe that will
You're
be.
talking about the end of June of a ruling, and you're going to have Congress pass something before August.
But remember, Joe.
No. It's not as if maybe it's not as if Congress isn't aware that this is going on. So as Jim said, there's an element of getting ready. Now, if they don't get ready, you're right. But if they do get ready, in other words, if they act like politicians, then the question is, will the threat of a CBO baseline, see, CBO runs everything, the threat of a CBO baseline force them to actually move a little faster than they normally would? I think there's a real question.
Well, think about it. I mean, look how quickly they moved in adjusting the baseline for the Class Act change.
Look, CBO, once the Supreme Court
CBO
rules,
had a position on that, you know.
right, but once the Supreme Court rules, it changes law. And even if they haven't redone a baseline, CBO will score the bill against what their interpretation of current law is. Chris, as usual, said much more articulately what I was trying to formulate up front, and that is that when that changes, depending on where that line is drawn about the number of states, for the Congress to come back and legislate subsidies in those states, whether it was in the same form as the ACA or different, would at that point be a cost.
So this is an argument for preempting the Supreme Court.
I think clarifying the law, if that was something
If
somebody
Congress
would do,
wants
would be
to
great.
clarify the law, if that's what they think is necessary, I don't think it is, but
This
I
isn't a
don't think they will.
theoretical issue. This has happened already, right? The Supreme Court made the Medicaid expansions optional, not mandatory, and they rescored the baseline in the aftermath. And they didn't do it in 30 seconds, but they didn't wait for August either. They waited until they felt they had some ability to do it, and that they'll do the same thing.
Thanks. Hi, Mike Miller. I'm a physician and health policy consultant, advisor. I want to come back to something Doug and Jim had mentioned in terms of tax season, because you all mentioned that Congress acts when there's a cliff that they know is coming or when something rises up and smacks them in the face. As Jim said, I think several million people may end up, when they do their tax filings, realizing they owe a tax for not being insured that they didn't see coming. And I'm wondering if you think that will create some kind of impetus for Congress to do something, a special enrollment period, so that people can then sign up for insurance in April, May, June, because otherwise there's no way for them to get insurance, and they'll end up paying that tax again in 2016 on their 2015 incomes. And there could be several million people who could be outraged that they don't have a way to avoid having that second year of a penalty tax. Any thoughts?
I do think that in addition to the reasons Doug mentioned, which is not related to the individual mandate, but the subsidies themselves, there's going to be a lot of turbulence around tax filing season this year related to the health care law. And my guess is that the administration will try to get out in front of it a little bit by, preemptively easing some of the worries of the of the filers by saying, again, that you're allowed to file for an exemption if you would like to from the payment of the tax, and you just have to file this form with the HHS. And the form essentially has a list of 13 reasons that you could cite for why you don't need to pay the tax. There's lots of different things. You had a house problem, you had to care for an aging parent. And the last one is any other reason that you had in 2014 why this might be a struggle for you to pay. And of course, everybody in America raises their hand at that, right? I've got a few things I could cite too. So I
don't think it's written exactly like that, but okay.
Yeah, but it is not that far. Yeah, it's very general. But anyway, my point is, I think there will be a lot of talk about if you don't want to pay the tax, you can get an exemption, and they'll be pretty easy on the public in 2015 filing season. But nonetheless, I still think there will be a political blowback associated with it. I don't predict how it'll play out.
I don't want to belabor this, but won't that create a blowback that the administration is not collecting all these millions of dollars in taxes that should have been paid in an oversight environment in the Congress?
Well, of course they didn't. They aren't collecting all the employer penalties that were supposed to be due in 2014 either, right? That's probably about $10 billion, by the way.
They did that in block, all employers.
Yeah.
As opposed to individuals that I have some cognitive.
All right, not to mention the fact that the overpayments of subsidies, premium subsidies, it'll be almost impossible to figure that one out too. Next question.
Yeah, this is Thomas Ward. I'm an economist at the London School of Economics and World Bank. But I want to go back to Chris's comment that I think is underlining the whole premise of ACA. And that was, you mentioned that bigger is going to be better. and to consolidate the hospitals is the best choice. But then that goes a whole
I didn't say
against.
that. Just to be clear, I don't remember saying that at all.
I don't think that was anything had anything to do with, there was no premise in the ACA that you were going to consolidate things. I think that's a market trend no matter what. The name of the game in healthcare is market power. You know,
Right,
you have
but
pricing
ACA
power.
is pushing that.
No.
It was happening before ACA
Happening
was
beforehand.
discussed. I mean, it was absolutely occurring.
It attempts to encourage integration across, care frequently within the same institution, but it's not necessarily pushing one institution.
All right,
to
so
violate.
let's go back to this. The question is, what lessons do we have from the Veterans Administration, from Medicare, that's actually got more fraud than the biggest healthcare insurances, combined baseline? And where's the innovation if you're making it all bigger and better? And let's learn from lessons from the financial world of too big to fail and the regulations with that.
Well, that's where I think you go back to Chris's point about the antitrust laws. The antitrust laws in this country are really enforcement mechanisms. They're not just regulations that say what you can do and not do. And you try and tweak those things is a very complicated mess that I don't begin to know how to do. On certain ways, there's more efficiency in some of these institutions. If a hospital wants to try and bear risk, I don't see anything wrong with them trying to bear risk if they want to do it. It's a different business and they need to learn in it. But there's nothing in that bill that was really designed to encourage consolidation amongst either insurers or providers. Well, but it's
I have to get into this at this point. This has been a wonderful panel on the subject of the day. But I have to follow up on the man from the Urban Institutes and these last questions. Somebody decided, and I think it's OMB because nobody in healthcare in their right mind would have done this, that somebody has to be at risk and and competition that way will bring down the costs overall. And so what we have now is we have doctors being forced into accountable care organizations and being put at risk. And the logical place to go for help is the hospital. So nationally, we will have more integrated systems of physicians and hospitals working together for the point of being at risk. Now, I don't want my physician at risk. And if you think about this a little bit, 50 doctors in an ACO in North Carolina, if they get hit with $2 million patients, that's going to affect their income. And this whole idea, which no other country in the world has used to try to solve their healthcare cost problem, is pushing us in a direction at local level. And when you combine this with, if you look at the ACA on the plans with $6,000 deductibles, there's no way to go but to narrow the networks and make it harder and harder for individuals to find physician care. I mean, it's happening. Now, what will be the end of this? You guys all, it'll take 10 years and Republican and Democratic administrations, and we'll figure our way through this. But it's a mess.
Okay.
I know you don't agree with me, Joe, because we've talked about this before.
Yeah, we don't have an answer for that one. Okay. Any other question? Okay, come on over here. Raise your hand again, please. Actually, the gentleman in the back, I think, was ahead. Sorry.
Thank you. Howard Bedlin with the National Council on Aging. Soon-to-be Majority Leader McConnell has stated that he wants to pursue regular order, which some think has interesting implications in terms of opening up Pandora's box for Senate floor amendments on many of the issues that we're discussing. Wondered if you had any thoughts on that.
Well, I like Chris. I was a staffer in the Senate for a fairly long time, and I will say that here's the notion of bipartisanship. I basically agree with Chris's view of what's happened to that institution in the last couple of years, that there's been a trend toward avoiding tough votes, and by avoiding tough votes, in a place where you're supposed to have open debate and free amendment, you end up not doing anything, right? Because everything's going to end up being a tough vote, So this does mean it'll be interesting for the Republicans because, for instance, every time they want to move something, they'll put a piece of legislation out. The Democrats will come forward with a minimum wage amendment, right? And, a minimum wage amendment probably passes in the United States Senate even in 2015, I think. It probably gets enough votes to pass. So they'll have to figure out how to dispose of that. Either keep it and send it to the president on whatever they're working on, or take it off and deal with all the political fallout associated with it. The general thought, though, I think McConnell's right about this, is that they have the majority, so yeah, they'll take on some water on a few things, but by and large, if they legislate, their ideas will get into the legislation more than the other side. If you don't do anything, none of your ideas will pass, right? So they're going to have to take some votes, and they'll lose some things as part of the Senate process, but that's just the price of doing business in a big, complicated country, And so I think he's got the right idea, do it, and, it'll also stiffen the spine of some people when they don't want to, if they have a position but they just don't want to state it publicly, they're going to have to start stating some things more publicly by taking votes.
I just think it's worth emphasizing again, the Republicans who are up in 2016 need some accomplishments to run on. And they also, their personalities, if you look at who's up, people like Rob Portman in Ohio, this is a state that's hardly real red. It's, these are places where their natural inclination is to be deal makers. He's got a long history working across the aisle, and all of that's going to lead them to do this, even though there is going to be some tough stuff.
Sean Hackbarth at the U.S. Chamber of Commerce. As was mentioned earlier, someone brought up that CBO is king. How does the reappointment or appointment of a new CBO director play into the healthcare landscape?
Can I just say that the power of the CBO has been greatly exaggerated? I don't remember my tenure as czar being all that glorious. The CBO works for the Congress, and the Congress, in the end, decides everything about this process. And CBO advises it, and that's all. It has some real expertise, and its only real power is the power of shaming the Congress, and that's it. So I think this has been fun. All these people chattering about the next CBO director. The job has its moment in the sun, but once the next person is selected, even if it's Doug Elmendorf again, no one will pay any attention for another 4 years, and that's probably appropriate.
Just to add to that, we should try to keep in mind that the idea that things have to be budget neutral is a political decision by Congress. It's not a decision by CBO.
Hi, I'm Caitlin Van Sant from the American Academy of Pediatrics. I was just wondering on the CHIP front, how quickly you guys see this happening next year. Obviously, it's a really important issue for my organization, but as well for some of the 2016ers that you guys were mentioning, this seems like sort of a no-brainer that they would want to try to get this done as quickly as possible.
Quickly in Congress usually don't go right. So, I think starting a new Congress is like a little bit like starting a locomotive engine, right? So it's going to take them a while to get the thing cranked up, and so I wouldn't anticipate real fast movement on that, honestly. They'll deal with it, but it'll take a little while.
I think there's really just two outcomes. One is they decide to modify the program in some even modest way, in which case, they'll get started after the locomotive's moving a little bit, or they'll just decide to just reauthorize it and extend the existing program, and they'll do that the day before they run out of money.
Yeah.
And the other possibility there is that if they wanted to do this, and Chris alluded to this a little bit, I think, that, you know, you could wrap a lot of this in the budget resolution, knowing what's coming. And you don't have to line everything up on a dollar-for-dollar basis. And you could do it in a much more flexible way while achieving deficit reduction, yet setting in motion a process by which you can fix physicians, you can fix CHIP and the like. Well, and then set the architecture in the budget resolution and then do it through a process like reconciliation.
And I was just going to say that probably good for CHIP. This legislation was reauthorized last time outside of ACA. Anything within ACA is somehow suspect. So, one, you start in a good place. Secondly, it's bipartisan. It was bipartisan at the time of enactment. Within 2 years, all 50 states took it up. And I think the argument that there is going to be uncertainty in the exchanges, regardless of what happens in the King case, you have a situation with children who have coverage who need to have some sort of predictability in coverage. It's just hard for me to believe that, and I should say one more point before I say it's hard for me to believe, which is, and if the debate is going to be around significant Medicaid cuts in another context in the budget, if I'm Republican leadership, I would like to have something good and solid and comfortable and bipartisan around CHIP. So I think the tea leaves are pretty good for CHIP. That may or may not mean that's good for the Medicaid program as a whole or exchanges as a whole. But if you're looking at vehicles for coverage, CHIP's is about as good as you're going to see.
Okay, well, we've hit 11 o'clock. I want to thank everyone for close attention to this great panel. Please join me in thanking.